Hi, good morning. My name is Prasad Shirvalkar. I am one of the pain physicians at UCSF, neurologist and neuromodulator. And have the honor, together with some of my mentors, Mark Schumacher and Lawrence Perret, of helping to host the second annual Neuromodulation Symposium sponsored by PARC. I wanted to, last year, I wanted to just comment, we kind of spanned the gamut of neuromodulation for multiple disorders. And this year, we really honed in on pain and addiction. How do you define neuromodulation? The Neuromodulation Society, the International Neuromodulation Society, generally defines it as altering nerve activity through targeted delivery of some kind of stimulus, right? So electricity or chemical agents, specifically to a particular neurological site. What's really, I think, inspiring is, especially in the last 2 years, and in the last year, it's become a reality that ultrasonic waves are becoming a mode of neuromodulation. For many years, magnetic fields have become a mode of neuromodulation in humans. And so I just want to bring recognition to the fact that we can neuromodulate nerves, or we can influence nerves in various modalities, but understanding how to do it in a personalized level to treat pain and addiction remains a big challenge. And hopefully we'll be able to educate ourselves and spark some discussion today. The agenda generally will go about until 12:30, and after this introduction, and Dr. Schumacher will give some words on PARC. And you'll hear a plenary, the first plenary from Dr. Yaksh, and the second plenary from Dr. Staats. And we're aiming to keep about for the plenaries, 30 minutes each, and for the talks, about 15 minutes each. And I will be tasked with cueing you when you have about 5 minutes left, and then 2 minutes left. All right, thanks. So Mark, would you like to come up here and say a few words?
Thank you. Also, I wanted to introduce Lawrence Perret, who will be helping moderate this session as a co-chair. I'm Mark Schumacher. I'm the vice chair for pain medicine at UCSF, as well as the director for our Pain and Addiction Research Center. We call it PARC. And with that, I want to just, let's see if I can get things rolling. Oh, right. I'm not sure I remember the slides I put together. So in any case, I also wanted to point out that PARC, is a transdisciplinary organization for UCSF and beyond, and we have a seminar series, and you may be interested in next month that we have one that looks at big data, non-invasive gathering of different physiologic factors and how it may help predict changes in addiction, and also can be translated to pain research as well. So I put a QR code up. If you're interested and you haven't joined PARC, please consider that. We're very fortunate that this symposium is sponsored by the Painless Research Foundation, which is really dedicated to reducing suffering globally. And they've been a consistent supporter for PARC over the years, as well as our Department of Anesthesia. Well, these are out of, we're not taking a break quite yet. Okay, let's see, and we're not discussing, and we're not having lunch yet. So I'm gonna back up on those. With that trip, I'd like to then move straight to our first speaker. It's my real pleasure and honor to introduce Dr. Tony Yaksh. He's a professor at the University of California, San Diego, my own alma mater. He received his PhD at Purdue University and has served not only in the US Army, but also through the University of Wisconsin, University College London, the Mayo Clinic, and now continues his work at UC San Diego. It's really remarkable to review Tony's career path. He has more than 900 peer-reviewed publications and numerous awards. I'm fortunate to be maybe one of the 160 postdoctoral scholars that he's mentored. And he continues to have NIH support over the many years of his work. Tony's work and research has been on the biology of pain and pain processing in the spinal cord. And he's really considered an international expert in spinal drug kinetics, as well as the evaluation of spinal drug safety. It's really my pleasure to introduce Tony. Please come up. Thank you.
Thanks, hey, thank you.
Mark, thanks. And I shifted by using these things here.
Correct. Okay. Exactly.
In other
And
words,
sorry, if you want to use a pointer, you can use the laser pointer.
Mark, in the words of Mark Twain, more than I expected, less than I deserved, but of course. Yes, it's my pleasure to be here. And as an expert, I have one thing that I will tell you, that being an expert means you know what you don't know. That's about the best you can say for it. So I was asked, well, I was offered this opportunity to come here, and I'm very flattered to have done so, to be here. And I'm going to talk a little bit about neuraxial drug delivery. And I've been presumptuous to call it disruptive advances. So that's, in my opinion. You may have different opinions after you hear what I have to say, but there you go. But you know, it's interesting, as in all things medicine, oftentimes advances occur because of concurrent developments in both technology and pharmacology, if you will. And I won't go into this detailed discussion here briefly, but the fact of the matter is that the development of a way to do hypodermic injections, that is, say, the syringe with a needle that could be attached, and one that you see here from the original, one of the early ones by Lure, and hence the name Lure-Lock, because of the idea that you could have a detachable needle, in conjunction with the development of a rather advanced pharmacology at the time, the appreciation of the role of coca in producing numbness of the lips, and then the pharmaceutical chemistry, if you will, in creating a purified form of cocaine that could be water soluble and could be delivered through that needle, enabled people like Halstead in 1885 to do a lot of perineural delivery all down the East Coast, showing the demonstration of producing distal extremity blocks quite effectively at managing pain without having to worry about things like chloroform and diethyl ether and so forth. In 1885, of course, at the same time, Corning did the first epidural, and it was like anything else. He put the needle in with the idea of injecting something in the overlying venous supply of the cord, but went in a little bit, felt pretty good, went a little further, heard a pop, and he was in the epidural space and showed in a dog the effects of reversible effects of cocaine in producing anesthesia. And then, of course, the big one was 1899 with intrathecal delivery by Beer. And for those of you who are interested in the history of these things, reading Beer's original description is quite impressive. So the idea that one could deliver drugs into the space was one that has had a long history. So I'm going to talk about three areas where I think that most of us won't find it very surprising, I think, but if we put them together, we think, things are changing a little bit as development occurs, in the same way that it did with the initial use of intrathecal cocaine. So first off, I want to talk about two things. One, we're obviously dealing with the spinal cord, and we're now interested in the targets that are in fact associated with the actions of intrathecal drugs. And there are two kinds of targets. One's the anatomic target. Where does the drug act? And the second are the membrane targets, which of course are the channels or the receptors. Well, Tom Reedy and I were able to create a small model that allowed us to give intrathecal drugs. And from the very beginning, we were able to show that the intrathecal delivery would produce a powerful analgesia. The effect was clearly mediated by something at the time we thought of as the opiate receptor, because it had the appropriate pharmacology. And importantly, this effect was associated with a powerful change in pain behavior, but with no change in light, touch, proprioception, that sort of thing. So it was highly specific. And the idea that, in fact, what you were doing was actually altering transmission at the level of the dorsal horn was not one that we had thought of, because work by a number of investigators, both here and in Europe, well as in Japan, had shown that if you study the effects on single unit recording from the dorsal horn and look, for example, at a wide dynamic range neuron, that the postsynaptic post-stimulus discharge that you see here This would be the A fibers followed by the C fiber post-discharge. That intrathecal morphine would selectively knock out post-discharge, but not have an effect on the initial A beta-driven phenomena. And of course, this had the right pharmacology and that the effects were reversed by naloxone. And over the ensuing period of time between 1975 and 1990, a lot was discovered about this, and it was appreciated. That effect represented presynaptic action on opiate receptors on C polymer nociceptors. This was in conjunction with all the discoveries being done with G protein chemistry, showing the GIO protein coupled receptors would regulate terminal calcium influx, regulating transport release, and increasing potassium currents leading to hyperpolarization. And I could go on down the list there, but there was a whole pile of things that came to be appreciated. So this idea that we could regulate specifically the dorsal horn reflected on the fact that the innervation of a module, if you will, in the dorsal horn that we were dealing with was the presynaptic C fiber talking to a second order neuron, and that this whole input-output function was regulated by things like microglia, and there were astrocytes in that tripartite synapse that we came to appreciate, and then a whole series of interneurons that could regulate both the excitatory and inhibitory fashion, the input-output function. And then, of course, there's the bulbospiral descendant pathways. So this was pretty much the domain that we were all working with as we studied whether or not regulating various aspects of these various components were in fact significant. That actually led to the appreciation that there was more than one receptor, the mu receptor for one. The delta receptor, obviously, with the work that was done by Hans Koskowitz in developing the enkephalins. And then, of course, the idea that the descending pathway regulated dorsal horn function through the release of norepinephrine suggested that there was a role for alpha adrenergic receptors. And so everything that we had come to believe was true for the mu opioid, was true for the delta opioid, as well as for the alpha 2. So this indicated that it was not just a one-trick pony. Now, obviously, I'm oversimplifying some of the aspects of that, but nevertheless, that was kind of the general organization. Interesting, I must have left out that slide. More recently, we've come to appreciate that, in fact, there is more to that story than just the idea that there was an effect in the dorsal horn mediated through an effect on presynaptic opiate receptors on that primary afferent. So now we recognize that there's an important role for the actual transmission into the dorsal horn through the dorsal root ganglia. And so now we recognize that, in fact, the primary afferent, the terminal out here, projects through to the dorsal horn. And of course, that dorsal root ganglion neuron is, in fact, associated with a whole variety of elements, such as the macrophage, the astrocytes, the satellite cells, that all regulate the excitability of that dorsal root ganglion neuron. Now, much could be said about this, but I'm only going to leave it at that particular point of it, to point out that this particular area here represents a whole series of cells that can contribute to the local release of products that can, in fact, have direct effect on the dorsal root ganglion. Now, what makes this data kind of interesting and relevant, if you will, is the fact that we know that if we regulate the excitability of, or the functionality of macrophages or the astrocytes by various knockouts or various kinds of toxin drug treatments, that we can change the excitability input-output function of the dorsal root ganglion neuron. So a number of studies have been done demonstrating that if you knock out, say, macrophage function, that in fact you can regulate the response that the animal would make to, say, for example, a nerve injury stimulus. All the stuff on the right side, I mean, we could talk about that again in detail. But moving on with the idea that I would leave you with the case that we believe that the dorsal root ganglia represents a really important element in the primary afferent to dorsal horn linkage. It's interesting that, in fact, we know that the DRG lies outside the blood-brain barrier. So many of what we call nociplastic pain states are likely mediated by the direct effect upon these particular structures. Think, for example, of fibromyalgia, where the data currently suggests that circulating immune complexes in these particular population of patients may, in fact, be producing the whole body anomalous pain conditions through their ability to penetrate into the DRG and have direct effects on this particular local circuitry. Now, this is where I thought the slide I was getting ready to show you. So based on the ideas between 1975 and 1990, it was appreciated that we could alter this small afferent input through the DRG, depolarize the C fiber terminal, activation of voltage-gated sodium channels, calcium channels, transmitter release regulated by that, postsynaptic activity on the second order neuron, leading to this spinal fugal output to higher centers. And so there were a number of things, strategies to, in fact, address that. The new delta opioids, the alpha 2s, the appreciation of the role of TRPV1 on the C polymodal nociceptor terminal. And I won't spend time going through this, but the excitements associated with understanding the post-afferent excitation, the categorization of the NK1 receptor, the role of the NMDA receptor of the NMDA channels in regulating excitability in the dorsal horn, the wind-up phenomena drawn from the hippocampal post-potentiation literature, that sort of thing, all fit in with the idea of this role of the dorsal horn. Then, I hope I sent you the right slides. So since that time, of course, now from this time, from 1990 to 2024, 2025, there's a whole raft of things that have now become apparent in regulating processing through the dorsal horn from the primary afferent to the projection neurons. So we have now afferent inputs that are associated with the understanding of the role of a variety of voltage-gated sodium channels, 17, 18, 19, changes in potassium currents, clearly regulating the excitability. And then, of course, within the DRG itself, a whole series of channels and receptors that are now known to regulate the excitability of the input-output function. At the terminal level, we recognize there are many ways to skin the cat, so to speak. Not only do we have the original ones, but now we have the CAP 2.2 appreciated, the role of snares, the synaptic proteins, and regulating transmitter release through the use of drugs like the botulinum toxins, a whole variety of glutamate receptors, GABA, neuropeptide Y. So again, the point I'm making here is not to go to suggest that any one of these is the way forward, but the fact that in fact they can be a part of the processes that are associated with the input-output function. And I would make the point here that we now talk about the DRG because with intrathecal delivery, of course, we do affect the dorsal horn. Once we traverse the peel barrier, we are in the mother lode, if you will. But what's really exciting is we now appreciate that that dorsal ganglion is directly accessible from the intrathecal space. And things, for example, like adenovirus transfection occurs because the AAV can actually move down the root sleeves and by mechanisms that are still not totally understood, make their way to transfect those dorsal horn neurons to, as I will say in a moment, decrease the expression of a variety of proteins. So the whole panoply of targets is not only an increase in the appreciation of the anatomic substrates, the dorsal horn and the dorsal ganglia, but also a whole series of, if you will, targets that are going to regulate the processing of input-output functions generated by nociceptive stimuli. So that's one major advance, or one major, I will say, disruption, but advance. Second, let's talk a little bit about neuraxial delivery platforms. Again, I'm not going to spend any great time on this, and I don't think I'll be telling anybody anything new, that there are many ways to deliver a pharmaceutical product into this restricted space, that's intrathecal space. One, we talk about small molecules, that's what we typically have, but there's been real advances in formulation chemistry, the use of nanoparticles of various sorts, which allow for the creation of persistent release products after, say, a single injection, whether it's in the intrathecal or the epidural space. Transfection modalities, including everything from viral and non-viral transfection technologies, RNA, changes in messenger RNA, the use of CRISPR technology. So you have epigenetic changes in cellular function, and then a whole series of these products being targeted at things we understand in terms of NAV, for example, the calcium channels and potassium channels, so we can upregulate perhaps their expression in the potassium channels. So we have antisense issues, a whole variety of studies work again with the idea of changing the genetic and the expression profile of that particular cell. Targeted toxins, things such as sepsis P safran, where one can in fact employ the ability to target the toxin to a very specific cell by virtue of its ability to bind to an epitope that is specific to a nociceptive transmitter, sepsis P being binding to the NK1 receptor. resniferous toxins, the TRPV1s that are expressed on polymorph nociceptors, even botulinum toxin and various variants of the toxins that target the synaptic release through their effect on snares. Decoy proteins, lipid raft targeting. We recognize now that a major component of cellular signaling, not just for pain transmission, but for a variety of different cellular circuits, represent sites of aggregation for a variety of excitatory channels and receptors, TLR4 receptors being co-localized, if you will, with TRPV1, with NMDA, et cetera. And activation of those channels, particularly the TLR4, can lead to the aggregation and activation, enhanced activation profile of that particular membrane. Exosomes, cells, in the sense of MSCs and fibroblasts, can be delivered intrathecally and have been done so. And then a whole series of things in terms of increasing transduction, either through the novel ligands, such as the DREDs, and then, of course, the optic and mechanical, which we'll hear more about today in the presentation a little later on today. So all these particular platforms can be provided for intrathecal or for neuraxial delivery, and we can target them into the dorsal ganglion, the dorsal horn, motor horn cells. And what this has given us is not only the ability to specifically target elements of the transmission that we may only presently poorly understand, but also we can now think in terms of regulating the effect duration. We can make many of these things, such as the CRISPR, conditional. So we can, in fact, produce the effects with the CRISPR reagents, the zinc finger reagents, and then make them so that they become active or inactive, depending on treatment with the drug, much like the DRED story. We can create platforms that are short duration of action, so days to weeks, versus those that are long, that is, say, months to years. In fact, those that are perhaps irreversible. And I would argue that many people who now think in terms of the adenovirus or these various stories of how long can we make the change in function last, that's not the problem. We can make it last forever, literally. But the problem is the 25-year-old football player that broke his arm or twisted his shoulder or had the Tommy John surgery or whatever, you don't want to knock out NAV 1.7 forever. You want to knock it out for 2 months or 3 months. And so the idea of producing a shorter lasting change in the epigenetics or the genetic profile of that particular cell, whatever it might be, is probably one of the more important challenges that we're undertaking to face. Now let's talk a little bit about neuraxial delivery systems, which seemed kind of boring. We have a catheter. That, by the way, is a picture of the red rubber catheter with a big side port that was first used in, not this particular catheter, but it was a urethral catheter that was implanted by a Mayo Clinic surgeon for managing hydrocephalus, and did it chronically, and that was in 1937. And that was the red rubber catheter that was in fact employed. So if you think about it, I don't think I'm telling anybody in this audience anything they don't already know on this slide. We know that the intrathecal space, of course, is where the CSF is present and stored. It serves as a buffer, if you will, to in the Archimedean principle of buffering the supporting the brain in its function. And we recognize that it's of course, the cerebral ventricles. We recognize that it goes down into the CSF space in the extracranial neuraxial portion of the spinal cord. We also recognize that there is no major flow patterns there. It used to be thought maybe 15, 20 years ago that there was this natural flow up and down the port, like the Mississippi River. And that came actually from some actual interesting observations made by a variety of individuals. But the point of the matter is we recognize now that if you actually intrathecally administer a small volume into that intrathecal space, that what happens actually is that it pretty much stays in that one area. There's local pulsations that do occur as a result of the cardiac cycle compressing the brain within the closed cranial cavity, forcing a brief pulse caudally from the cerebral ventricles. Then there are the pressures that are generated by as a result of the respiratory cycle that forces blood back into the peridural venous sinuses, So you get this very complicated ebb and flow, but it's pretty much localized. This CSF thing, the CSF movement, this was from MRI now about 30 years ago. Well, 20 years ago. And it's just showing that during the cardiac cycle, there's this rostrocaudal movement that's very, very localized. So the intrathecal space, the CSF space, is not so much a river as a Mississippi bayou. There's the ebb and flow that causes local distribution, but not a major shift. Well, this represents a challenge for drug delivery. That is to say, we recognize that these small volumes of injectate delivered over time for extended periods, they tend to pool around the injection site. The picture you see on the right, well, Chris Bernards was a good friend of mine and unfortunately passed away, but was really made some major contributions. Did the very simple study of taking pigs, and they actually did them vertical pigs because there's worry about rostrocaudal flows in a pendant versus a supine animal. And this is after approximately 48 to 72 hours of infusion of a dye through the intrathecal catheter. And yes, there is a distribution around the catheter site, the dark part being where that is. But you can see that, in fact, it's pretty much limited to that local level. And on the left side there, this particular diagram here represents the distribution of morphine around the catheter site in these pigs when they were measured in the tissue. And you can see that the majority of the activity was within several spinal segments of the injection site. So this is a problem because we know now that, in fact, much of the afferent traffic that goes into the dorsal horn, if EFIT comes in through a single route like L4, that the collaterals that come off of that may go as much as 4 or 5 segments rostrally. So for a drug to actually be effective, if it's focused on the terminal, it has to get away from the terminal side of the catheter side of delivery, rostrally and caudally to that particular thing. So there are 2 problems here. One is the pooling around the injection site, which means that high concentrations of drugs are going to be exposed to the local tissues, which is associated with a significant pathology, potential pathology. And then secondly, the idea that we do need to pick rostrocaudal distribution. It's not a question like a local anesthetic blocking a single route, but in fact, if the terminals are where we're focusing, then we have to expect that the drug has to get a number of segments away from that site. Now, there are a couple of ways we can do that. We can increase the volume very easily. So we increase the volume and we can push distribution quite significantly. But on the other hand, if you have a pump system, then in fact, you don't have that particular option because a 20 mil pump delivering 2 mils a day would in fact only give you 10 days between refills. So the majority of pump deliveries are in the range of 20 microliters an hour, which gives you a particular long time between refills, but it also means that you have this very localized event that you see in this particular area. Ironically, increasing injectate concentration will do the same thing because there's a rostrocaudal distribution of the injectate around the injection site. So basically, the concentration of the solute that you've injected will be a fraction of the amount of volume of that injectate that reaches the various spinal segments. So by increasing the concentration, you increase the concentration at the site, but you also increase the concentration at that site 5 segments away. But of course, now we've overdosed the site of where we've delivered the drug, and we push to achieve the rostrocaudal extent. I personally think that one of the issues of why in the pump literature we see concentrations of 10, 15 milligrams per mil being used routinely, whereas if you gave a bolus injection of half a mil, 100 micrograms would be an incredibly powerful analgesic effect. And the same thing happens in animals. Now, here's an example of how we can change the rate, perhaps, not the total volume, but the rate. So what you're seeing here is a 2-dimensional flow chamber with this happens to be just one of the available catheters. This is the Medtronic's catheter. And we're infusing at the top there at 0.33 microliters a minute. That's 20 microliters an hour. Over this period of time, where we infuse for 10 minutes, we deliver 3.3 microliters. And if you look kind of closely, you can see this catheter, though there are multiple ports, everything is coming out that first port. And you can see that there's a fairly dense concentration of dye where that port is. On the right side, we see the same experiment, but now we're infusing it at what at the time, what is now called in the literature, the bolus dosing for this particular pump, this Medtronic pump, which is 1 ml per hour. That's 16 microliters a minute, 3.3 microliters over 10 minutes. So we gave the bolus as opposed to doing a continuous infusion. So same total dose was given, but using the more rapid delivery component. And you can see that the dye itself shows this very clear pericatheter movement away from the catheter site. Moreover, it's hard to see in these images, but actually we're seeing fluid come out of more than one of these ports now. On the right side, you basically see just a summary where the red is the continuous infusion, and you can see the high concentration, in this case, the dye around the pericatheter region, and it falls off very, very steeply. Whereas if we use a bolus where we're increasing the velocity only up to 16 microliters a minute, which hardly constitutes a bolus in my opinion, but it's faster than giving it by continuous. And you can see that there's this lower peak thing and a greater spread. And when we measure exit velocity, just by measuring the distance versus time, the infusion exit velocity from these ports is on the order of 0.02 millimeters per second. Whereas when we do the 16 microliters per minute, you see that it goes up to 2.3. Hardly a bolus delivery, but that little difference there that you see in the dog study resulted in a loss of the ability of 20 milligrams per morphine to produce a granuloma. This is work that Philbrand at Medtronics and I did on this particular study. So if we can increase exit velocity, because that's what we're doing here, we can increase the local dilution, and therefore we can reduce pathology. Well, so how can we increase exit velocity? Well, it turns out that the exit from a catheter is going to be related to the size or the resistance for the exit. So if you have a fixed orifice, it's fairly big, fixed resistance equals X. It doesn't change. But suppose we wanted to make it so that the catheter was infinitely resistant. So we, instead of using an open hole, let's use a valve, a slit. And if we do that, the initial opening pressure is infinite until the transmural pressure gradients around the catheter, in fact, exceed the opening pressure of our valve. Then you have the material being expelled, and that expellation is now being driven not by just a simple volume, or simple rate of the delivery, but you're now working against a gradient. It turns out that the slit valves that we use or we generate actually require about 70 millimeters of mercury pressure to open. So you're driving out the fluid with a gradient of 70 millimeters of mercury. And the consequence of that is, if this works, let's see if it works. Ooh, it doesn't, unfortunately, oh, it doesn't work. Sorry about that. So if I were to be able to activate this slide, what you would see is there are two ports here. One's here, and it shoots out like you would go, at least most people do when they see what it looks like. So I don't know why I can't make it work, but that's not surprising. So anyway, so
yeah, you can click on the play.
well, oh, it did appear. That wasn't here just a moment ago.
Oh yeah.
No, I think.
Maybe. Yeah.
Well, I don't know. It's not doing. I'm sorry about that, but all right. You think you can make it work?
Yeah.
Bless your little heart.
Let's just go with
Yeah, he does point.
that. I know, right? Yeah.
I mean, for me, it's like, look, right here.
Yeah, right.
Did you get it?
Exactly. Let's turn that off. There we go. There we go.
Oh. See? Ah, thank you. That's the right response. It makes me feel so relaxed. When people go, oh shit, that didn't seem good. Well, but seriously, it amazed us. I mean, we knew it was working that way, but it wasn't until we actually started doing this high speed microscopy or imaging that we began to see that. Now this is great because you can imagine what this does. The exit velocity here, I won't go into it. We access some of the data, but you can see it's very, very high. In fact, I want to show you one more thing, if I may. I don't want to waste your time. If I were to run it continuously, but you see what's happening here. It's actually interesting. You actually get the valve actually oscillates. It's hard to see, but there are actually two expressions. You get an initial boom followed by a second boom later as the compliance of the native compliance of the catheter provides pressure in its own right. Now we're not doing anything special here. This is just a simple bolus delivery. In this case of about, well, this is one of a number of catheters. There you go. Okay. So there's more that came out of this because it turns out that this is the normal way to think about it. Big holes, everything comes out the first port, which is what you saw. But in this case, we have an infinite resistance. So the fluids, the transmural gradient between the inside and the outside before the valves open is actually the same. So we've increased it to X millimeters of mercury, and then at some point it hits 70 millimeters of mercury, or whatever the opening pressure is, and out comes all the valves open concurrently. So now you're distributing a small volume of fluid over a very large space. And this is what you see. This is again a two-dimensional diffusion chamber, and this is at before. This is at 15 seconds, 4 minutes, 8 minutes. But you can see the other thing you see is this, very typical. This is the high velocity fluid phase coming out of the slit, leading to, as it intersects or converges with the static fluid of the local milieu. So you get this kind of mushroom cone. And if we continue on, you see that what happens is you get this total drive to diffuse the fluid. There's a consequence to this activity. One, if you do this in a rat, on the top you see the effect of a single open-ended catheter with a blue dye. You see everything is around the lower lumbar. Yet if you do this with this catheter that I just described, you see the blue dye extending from the catheter tip, which is down here in the middle of the lumbar, all the way on up to the cervical cord. And this just simply represents a composite of five or six of such rats. And you can see that at the sacral and lumbar at the very top up there, where the tip is, you can see that it's all around that. But by the thoracic cord, as you see here, nothing. Whereas with this microvalve, polymicrovalve, you see that there's this even distribution all the way on up to the cervical cord on average. If you do something like, for example, transfection with adenovirus in the rat, this is just transfected in cherry, and I screwed around with contrast to make it pretty visible, so it looks less, it doesn't look very precise. But you can count, obviously, the transfected neurons here expressing in cherry. This is an E10, and you can see that the polymicrovalve catheter, you see the expression all the way on it through. The thoracic oftentimes shows a reduction, and that's because of the small volume we think, and it just gets squeezed away from there. But if you do the open-ended catheter with a single pipe, notice that everything is, you've got enough at E10 to do down the lumbar, but you don't see anything up there. You go to E12, well, the open-ended catheter now has the ability to produce transfection all the way from one end to the other. And of course, the E12, the DNV just shows more of the same. So there's a concentration dependent.
Tony, sorry, we're almost out of time.
Okay, well, I'm not, I'm 2 sides out, 3 sides out. Okay. All right. All right. So that's that. I want to leave you with this idea, though. Pain is more than just the sensation. It's the whole story. So you may ask yourself, how is it that is it possible that the intrathecal delivery not affecting the brain is having an effect on other aspects of the animal's pain? And it turns out we know now that in fact the ascending pathways go up, of course, to the classic somatosensory pathway, the events that are occurring associated with the sensory discriminative component. But we also know that there's this projection up into the more medial pathways that are associated with the effect of motivation. And it's significant to note that when you look at literature where you compare the ascending pathways in terms of their output function, as on the upper right there, where one does ventrolateral chordotomies, in that case with a spawning needle, one in fact changes not only the human's response to, oh, I don't hurt, my femoral osteosarcoma doesn't hurt. There's also a change in the psychological aspects. And it's interesting, in the animal models, we can say that by using conditioned place preference. And I know I got to not go over this, but it turns out if you take an animal with an L5 ligation, they have a tactile allodynia. We can block that tactile allodynia with various doses given intrathecally for some drugs, such as these, but not for an insect, when you say urolite. And so these are the effects on the allodynia. It turns out that these animals are these drug therapeutics that work on the allodynia also produce a conditioned place preference. Again, there's much I can say about that, but I'm just leaving it at that. So I have one more slide after this one, and this is it. So this just summarizes everything I've said. Importantly, there are advances that occurred with regard to therapeutic and neuraxial targets. There's therapeutic delivery platforms that are going to allow us to be able to deal with acute, transient, and persistent pain, reversible pain perhaps. And then finally, there's these delivery systems that I think is important for advancing the project itself. And this is just worth reflecting on the shared pain. It's all about the money, right? So it's the shared pain funding collaborative from these three institutions that I've had a great pleasure working with. Thank you very much.
Thanks so much. We have 5 minutes for questions. Yeah, Ada.
I assume what we're actually using it particularly is the thing we've always had, which is the hole in the catheter, right? Instead of a slit. And
I'm not clear what you.
so you were talking about how having like a slit in the catheter would, basically would change the distribution. And that's not what we're using now,
No.
I assume.
Your assumption,
Yeah,
you saw
so
the red rubber
yeah.
catheter. I actually have another slide that shows the development of the catheter since about 1937. You wouldn't tell the difference.
Yeah.
And the only difference is the materials that are used to construct it.
And to give you like, so I'm a nurse practitioner, I work in our pain clinic here at UCSF. I do like a lot of the hands-on pump management. I guess I'm wondering, at like the clinically, like, how do you think having a slit might change what we see in like pump failure? Because I know if we have kinks or if we have something else, including the end of the catheter, we tend to see much earlier high residuals when we're doing pump refill.
Right.
And so if there's a higher,
Well, remember, the resistance is not infinite.
yeah.
I mean, we construct the catheter to have opening pressures of about 70 millimeters of mercury because that gives us a really reliable, it's easy to do. But we can make them lower pressure by simply changing the, it's not, we're calling them slits. They are slits, but I mean, that's the easy way to describe it. It's a bit more than that. But still, it's the opening pressure from an infinite resistance to an opening pressure that actually constitutes the parameters that we're dealing with. And so you're right, if you have an infinite thing, the pump's going to fail, but that's not the point here. And the other thing is that remember, there are ways, notice that bolus delivery did better with the Medtronic's pump because we think because you get delivery. But future pumps are likely not going to use a continuous rotary system. They're going to have valve systems that give you square wave delivery because you're using the pump, the energy intrinsic in the activity of the pump to in fact deliver, to drive the delivery through the catheter. And I think that's a major shift in thinking. Yeah.
Only one more. Thank you very much. I hope you have developed some colleagues who can carry on your information and knowledge because right now it's a little sparse on people that have your understanding of this field. But thank you very much for the summary. On the clinical side,
The way you were starting that, I'm thinking, do I look like I'm getting ready to
are you
fall
ready?
over? I'm ready to quit.
Are you ready? Well, you're in a good audience. If today's your
Yes,
day,
I know.
you're going to survive.
I don't know. Can you get me down to San Diego?
So I have a simple clinical question. I've placed got more than a couple of thousand pumps, managed many more than that. And I have a preference for the continuous infusion. In today's world of low dose infusion, granuloma mitigation is not as big an issue. But based on what you say, if I used a continuous infusion daily, do you think that one single bolus per day, higher volume, flushing out the local concentration of the injectate at the site of the catheter tip would have any theoretical value in granuloma mitigation?
Well, I honestly do. And the reason I think that is because we've already, I think there's some of the early work on pathology used bolus delivery and granulomas weren't a problem. It's the continuous high concentration. With regard to the issues you raised, these one and done in the pathology studies, we actually were doing divided doses. We were able to show that if you did ×1, ×2 divide dose, ×4 divide dose, that you got the same effect. So with kinetics of the drug being what it is, you're injecting drug every 6 hours. I mean, again, there's a lot more work to be done here. Hopefully NIH and their wisdom of funding grants will appreciate that when we submitted this stuff. So yeah, so it wouldn't be one one a day. It'd be every 6 hours or every 4 hours.
I gotta say, every 4 or every 6?
Well, I mean, right now,
With
we've only done 1 day bolus. We've done 2 daily pizza. Again, with the total dose being the same. So if we inject, if you do 20 microliters an hour, it's 0.48 mils a day. 0.48 mils a day times 1, half a mil, no big deal. Twice a day, it'd be 0.24 mils every injection. 4 times a day, we can do the math. And so the idea there is we're giving the same total dose, same total volume, but divided. That's all we're doing with that.
I have more questions for Prasad.
I'm sorry to play the music. Yeah, sorry, Tony, thank you so much. There's one final question on Zoom. If you could clarify on the last experiment that you described, what level was that catheter at for these studies?
You're talking about the condition place prep.
Correct.
Those are all lumbar catheters.
Lumbar catheter. Okay, thank you so much.
By the way, I didn't talk about the one slide I showed there, but it turns out that if you're trying to block the four-limb formalin flinching, which is what this slide right here is showing, the one before, it turns out that that with the open-ended catheter, the dose response curve is such that you just don't get anything after a lumbar delivery. But if you have the poly PMD catheter, you get equal analgesia in the forelimb and the hind limb. So we're getting distribution. And then the same thing holds for the end-cherry expression, where we get even distribution of transfection from the sacral all the way up to the cervical. So it's not a big deal, actually. It's when you think about it, it's all kinds of sense.
Oh, I hope we can see that in humans one day. All right. Thanks. Lawrence, you want to come up here and introduce
Yeah, you can do that. So it's my pleasure to introduce Dr. Peter Staats. Dr. Staats and I go back, well, a little bit before the dark ages, but we both were at the University of California, Santa Barbara. He's a fellow gaucho from there and has a long history with his time here at California. But in addition to that, he's gone on to do his internal residency in anesthesia and became the founder of the Johns Hopkins Division of Pain Medicine. From there, he went on to become the president of the World Institute of Pain, the president of the North American Neuromodulation Society, and the current president of the Vagal Nerve Society. He's been involved in international research and development for many decades, as a leader around the world in these topics. And we've asked him to come here today to talk about vagal nerve stimulation. Definitely ask him all the questions you want about vagal nerve stimulation, because he's in fact literally written the textbook Vagal Nerve Stimulation, which just came out this year. Welcome you to come and get that book and get your copy of it as soon as you can before it sells out. And so therefore, I'd like to welcome Peter on up to discuss the latest in vagal nerve stimulation as it relates to addiction. Thank you very much for coming out, Peter. Comes from Florida to visit with us today, so we're really delighted to have him here. Thanks so much.
Thank you.
So thank you very much for having me. It's truly an honor to be here with you. I was reflecting with Mark. I think it was about 29 years ago. It was the last time I came and I gave grand rounds at UCSF. And so it's been a wonderful time. I know I was 7 at the time, so that explains it. Anna last night, where's Anna? Anna said that Tony Yaksh was the warm-up band for me. And that's like telling somebody that Bruce Springsteen's your warm-up band. It just doesn't happen that way. It's just a incredible honor to follow Tony as well, who I think I became a neuromodulation specialist because of reading Tony's work over the years, what he was doing with intrathecal therapy. And over time, my path has morphed, but Tony was my inspiration. And I still think that Nobel Prize that you're going to get on this space is still coming for you at some point, but you may have to wait. I'm going to talk to you about vagus nerve stimulation and specifically in addiction. And transparently, I am not an addiction specialist. I am a neuromodulation specialist, and I've spent a lot of time understanding the vagus nerve and also trying to kind of rethink paradigms of how we deliver care across different disorders. You can see here some of my disclosures here. The relevant disclosure is about 20 years ago, a little more than that, I started a company called Electrocord, was a co-founder, really trying to understand what the vagus nerve does. And we started with implanted technology and then morphed into non-implanted technology. And I have, in some way, been working with that company over the last 20 years. I'm not going to talk about any names or device specifically, but that would be really my only conflict of interest, and you need to interpret that as such. Now, Mark and Prasad and Lawrence asked me to speak about addiction, and I know enough about addiction to know what I don't know, but I also know that it's been an incredible failure of what we've been doing in the United States in the treatment of addiction. And I'll go over a couple of the demographics of this, but we spend $1 trillion on the treatment of addiction, and yet we have an incredibly high mortality. And I think it's important for us to all stop for a second and say, okay, we've been trying this for a while. I think it was somebody said the definition of insanity is doing the same thing over and over again and hoping for different results. So I think what we need to do is think about things differently, which involves changing our thinking patterns. Einstein said, without changing our pattern of thought, we will not be able to solve the problems we created with our current patterns of thought. And I was thinking about this in the realm of addiction and how this really may be the case. And I'm going to create an argument for you today that some of the strategies that we've been doing, while well-intentioned, are failing, and suggest that over the last number of years, we've understand a lot more about the pathophysiology that's occurring with addiction, and suggest there may be other ways with use of neuromodulation in particular here. So I want us to rethink addiction. I mentioned that we spend over $1 trillion a year on the treatment of addiction. And in spite of this, we have a very high mortality. And we see different schools of thoughts out there. We see a school of thought that says addiction is a genetic disorder. And that kind of just passes the buck in my mind. It doesn't really answer the solution. And I'm not saying that any of these are wrong, by the way. I just think we need to broaden our scope. We can tell people to abstain as we do with Alcoholics Anonymous, or interestingly, we can say it's a behavioral problem. And when I got started in the pain space, I was told that I couldn't do an epidural on a patient because I was reinforcing bad pain behaviors. That was just 30 years ago that we were told that. And we've learned about the neurophysiology that it's more than just a behavioral problem. Now, it's not that it's not a behavioral problem, but it's part of that. And then I think that the leading approach now is if you have a patient with opioid-induced addiction, our primary treatment strategy is give those patients opioids. And that's where I want to get into the pattern of thought. Is that the right strategy? And maybe it is, but I'm just going to challenge that here. So in the 2023, 110,000 Americans died from a drug overdose, 80,000 of whom were attributed to opioid abuse. There are a third of adult Americans had an opioid, and 2.1 million Americans are affected by opioid use disorder. There's some demographics out there. Anybody can get into problems with this, but there are some socioeconomic patterns associated with addiction. One of the things that I found very interesting in reviewing stuff is that family history of childhood neglect is associated with later lifetime abuse of drugs. And pulling together other areas of my work, we found that areas of abuse as a child has translated to development of chronic pain syndromes. And there's a whole theory out there called the polyvagal theory that this is due to the damage to the vagus nerve. And people have a propensity for injury because the cells are not ready for repair. So that's probably a talk in and of itself. There's a very famous psychologist who's been talking about polyvagal theory in terms of abuse and trauma, and that the cells won't repair themselves if they're not in an adequate parasympathetic state. Now, looking at not being an addiction specialist, I of course went to the NIH to say, what do we recommend for addiction? And the treatment strategy for addiction, medication should be the first line of treatment, usually combined with some type of behavioral therapy or counseling. To my point, that is what we do today. And I'm going to concentrate most of the presentation on opioid addiction, but there are addictions to many different treatments. You can have a nicotine addiction, alcohol addiction, opioid addiction, among others. And the problem that we get into addiction that makes it so difficult, particularly with opioid addiction, is patients, when they abstain, go into withdrawal. And this can be incredibly painful and difficult for patients who are trying to abstain. And it drives patients to stop their abstaining because they want to take something to get out of discomfort. They develop nausea, vomiting, diarrhea, anxiety and fear, pain, and you can see some of the other things. And I bring up the first 5 here because this is, again, from the NIH. These are areas that have all been demonstrated to be modulated by the vagus nerve. So a rationale for starting to think about some of the symptom control associated with withdrawal. Our treatment strategies, as mentioned, have been really 4 different treatments. Mu-opioid receptor agonists, methadone, buprenorphine, which is a partial opioid receptor agonist, naltrexone, mu and kappa opioid receptor antagonist, and lofexidine, which is an alpha-2 adrenergic agonist, which helps with some of the symptoms of withdrawal. The issues that we get in the standard of care, which is what I see mostly is patients with opioid use disorder go on methadone maintenance. And that's a mu-opioid receptor agonist that we're giving to people to decrease the withdrawal symptoms and decrease the cravings. Yet when you start to think about the receptor pharmacology, what we are doing is we are activating the mu-opioid receptor with the use of methadone. It is not an easy drug to work with. If you don't escalate quickly enough, people will leave treatment facilities. And if you escalate too quickly, patients can have respiratory depression and death with inappropriate use of methadone. In addition, if people have been abstinent for a long period of time, use and then come back, people can get into trouble again because they've lost their tolerance. Buprenorphine, more recent drug, developed in 2002, or not developed, but approved by the FDA in 2002. And again, you need to escalate quickly if you're going to get patients adequate treatment. And naltrexone is a different strategy, which just blocks the opioid receptor and really will keep people from wanting to use opioids. Now, when I stop and think about what I see as the difficulties that we see, and it's not just the pharmacology that's difficult. We have a very difficult time keeping people on these therapies. Patients leave treatment programs if they're not doing well. I think we need to come up with new strategies, and I'm struck with the thought that the light bulb was not just an iteration of the next candle. It is, in fact, a new treatment, a new approach, or new light on a new problem. And I believe that we're of the era that we need to start taking a look at alternative strategies. I'm not alone in this. Dr. Volkow, who is the NIDA's director, wrote a note for an annual address in 2025 in January, and she said that transcranial magnetic stimulation was already approved by the FDA as an adjunct treatment for smoking cessation. Peripheral auricular nerve stimulation was approved by the treatment of acute withdrawal, TMS, transcranial direct stimulation, and peripheral vagal nerve stimulation are under investigation for other substance abuse disorders. So, and there are others. I know we're going to hear about ultrasound. That's going to be another interesting topic later today, but these are, we're starting to evolve our thinking about this. My shameless plug is I went to the book that I just edited to try to get some of the information about this, about addiction. And Stephanie Washburn, who used to work for me, had written a chapter for me on vagus nerve stimulation in addiction disorders. And so this is where you can get a pretty quick read on this if what I'm saying isn't particularly clear. So what I want to spend just a couple of minutes on is understanding what's going on in the brain. And I want to do this to suggest to you that there may be an alternative strategy other than giving patients opioids for their opioid addiction. So what is happening in patients with opioid addiction? The ventral tegmentum area, it's an area of the midbrain, is the reward system pathway. This is the area that's activated during pleasurable encounters. The ventral tegmentum area does have opioid receptors on it. So an opioid activates the ventral tegmentum area, which then has multiple different pathways. I've only shown two here for simplicity, but one is to the nucleus accumbens and the other is to the prefrontal cortex. And so the ventral tegmentum area releases dopamine in response to pleasurable experiences, including opioids. This then activates the nucleus accumbens, which is in the forebrain. It's a dopamine target, mediates motivation, experience of pleasure, and it strengthens neural connections and increases the motivation to seek out those same pleasurable stimulus. The prefrontal cortex mediates the cognitive control over behaviors around decision-making and impulse control, and we also receives dopamine from the ventral tegmentum area. So if you're not a brain neuroscientist, I'm going to just summarize it pretty quickly for you. In the acute phase with chronic opioid use, you're binding to the ventral tegmentum area. I'm going to just go back to show you that picture, the ventral tegmentum in the midbrain. It increases the release of dopamine, which is the reward system, and it sends signals to the nucleus accumbens and the prefrontal cortex. There are other areas that I will get to in a bit that expand on this thought. Chronic opioid use, on the other hand, decreases dopamine sensitivity, receptor density, decreases the amount of dopamine production, changes the prefrontal cortex, changes the lucus coeruleus, and allows changes in the sympathetic activity that you see in withdrawal symptoms. You see unopposed sympathetics, and you see may drive a decrease in pleasure for most activities. So for all of us who have treated patients with addiction, they really lose their engagement in life. And this is a direct neurophysiologic response. This is actually a methamphetamine user, but when somebody's been using drugs for an extended period of time, I could have found something similar to this for opioids. The amount of dopamine that's being released or activated in the brain is dramatically decreased. Okay, so I talked to you about the VTA, the nucleus accumbens, the prefrontal cortex. What does that have to do with the vagus? Getting to finally why Mark asked me to come and talk about some of these things. The ventral tegmentum area is directly modulated by the nucleus tractus solitarius. So I don't know if I can show anything. No. So the nucleus tractus solitarius is the NTS. That's where the cell bodies of the vagus nerve come in, and they activate the locus coeruleus, the VTA, which then modulate the various structures involved in pain addiction, opioid addiction in particular here. So these are very central areas. And the focus of my work over the last 20 years has been what happens with the vagus going to the NTS and where it goes from there. This is a nuance for me in understanding how this modulates addiction. I'm going to just pause for a second and give you my bias here. My bias is that we've made great progress in medical advances, and we have conceptualized the human body as a big chemical organ. Tony's lecture is awesome. And I listen to them 3 times a year, and I still can't keep track of all the different receptor systems that are in there. It's an amazing achievement that you've done. And somebody once told me, don't say but say and. And I would say we've made great progress with, things like antibiotics, targeted chemotherapy agents, concentrating on that aspect of the human system. But I would agree with my good friend Albert Einstein here, who in 1934 said that the future of medicine is the future of frequencies, and that the physician of the future will be a master of both the chemical and the physical side of man. And what he was referring to in the physical side was electrical frequencies. And I'm going to argue to you that we are an electrochemical being, and the chemical side is extraordinarily important. But we've been like horses with blinders on, not being able to see a whole other area that's out there. And that's what the electrical side comes in. Now, what do you all see here? Peanuts. Peanuts, very good. What does peanuts have to do anything with what I'm talking about? Probably nothing, actually, but I wanted to show my peanuts there. Truth is, I was a neuromodulator, as mentioned. I was very interested in how the nervous system, how we can control pain and movement disorders with neuromodulation. I was president of NANS, and I was reading great work by scientists looking at, cardiac perfusion with neurostimulation, and thinking about the other things that you can do with neurostimulation beyond pain. That was really just a fascination of mine when I learned my son had peanut allergies. And in peanut allergies at the time, the only thing that you could do some years ago was epinephrine. Really, that was it. There was nothing else. We didn't actually know the neural innervation of the lung 25 years ago. We didn't know what it was. And I went to the lab and tried to figure that out with Chaz Emola. Chaz was with me at Hopkins and moved over to Columbia, and we figured some of these things out. We started to, took an animal model, infused histamine, measured airway reactivity and airway pressures, and found that if we stimulated the vagus nerve in an animal who we were giving histamine to, we could blunt the airway reactivity. We figured out how to do this non-invasively, which is this blue line over here on the bottom corner on the left. And at a certain point in time, and while we were studying patients with status asthmaticus, the patient started this. I said, "What else are you experiencing?" And someone said, "My headache went away." And that's when it really started to dawn on me that we were stimulating a structure that had really broad and profound effects on different organ systems. The New Scientist is a very popular journal. They did an article about a year or so ago that says that unraveling the secrets of the vagus nerve will revolutionize medicine. And I actually believe that's true. It is the predominant nerve that controls most of your physiological functions. Most of your physiological functions, your GI tract, your pancreas, your pulmonary tree. It also does quite a bit in the brain as well. And it's just been an underappreciated target. Now, I want to be very clear that I'm not saying go out and just stimulate everybody with addiction disorder with vagus nerve. I'm positing that this is a new avenue. I'm going to just give you a little bit more on the vagus. If you're anything like me, as an anesthesiologist, I knew the extent of my knowledge was, okay, that's causes bradycardia, and don't hit it when I'm placing a central line. That's about what I knew of the vagus. But the vagus nerve is the longest cranial nerve. It is the only nerve that leaves the brain area and goes down into the gut. to the thorax and to the gut. It is how the body gets its information, how the brain gets the information on the status of the body, and the brain actually controls the physiological functions of the body. That's a talk in and of itself, but controls the organ systems. And again, the tracts come in through the nucleus tractus solitarius, goes up to the brain. The vagus, when we start to think about the complications people have with withdrawal symptoms and addiction, also has efferent branches that come down. There are 4 branches in the neck, and then it comes down through the thorax and alters the parasympathetic function of the body. You can see here a few of the different structures that are involved, that have been studied and are shamelessly in the book. Mood, speech, headache disorders, post-traumatic stress disorder, all of these are thought to be modulated by parasympathetic function. There are many, many people studying different aspects of things. And again, what we're talking a little bit more about today is opioid use disorder, but there are people are studying this for all kinds of different problems. Now, one of the reasons that it's been difficult to really embrace this as a transformative therapy is that we've had limited ability to actively really know that we've been stimulating the vagus nerve until recently. In 1997 or 1985, the first studies were done with implanted vagus nerve stimulation for epilepsy. And in 1997, the first implanted device was approved for epilepsy. But an implanted device is a $50,000 operation, carries about a 5% risk of hoarseness with implantation. And it's hard to leverage that to the number of different areas that are out there. So we stop and think about how can we stimulate the vagus nerve? And this is probably the most ancient method that we've used for pain control over time. Yoga, acupuncture, pranayama yoga, cold water plunges, all activate the vagus nerve naturally. Deep breathing is another tool that's used commonly to activate the vagus nerve. I mentioned early on in the talk about polyvagal theory. There's a very, if you search polyvagal theory, it's a very popular approach in neuroscience and psychology and social work on threat physiology. And Steve Porges founded what's called the Safe and Sound Protocol, which is a sound acoustics that activate the vagus, somewhat widely used across the globe. There are implanted vagus nerve stimulators in the cervical region, in the ear, as well as in the fundus of the stomach. There's non-invasive auricular devices on the auricular branch of the vagus. It's a little small branch of the tragus. Now, interestingly, I still haven't figured out, after studying this for 20 years, why they call that the vagus nerve, because that little branch that you will read about over and over and over does not go to the nucleus tractus solitarius. It is completely an efferent branch, actually completely an afferent branch that has only sensory, doesn't go to the nucleus tractus solitarius where the cell body is, but it goes to the trigeminal islands. But conventionally, that is considered a part of the vagus. And someone will explain to me where my misunderstanding there. And then we have in the neck where we can stimulate non-invasively all of the fibers of the vagus as much as we want to. And again, there are about 160,000 fibers in the neck. There's about 1,000 fibers in the ear. And the ear fibers are all sensory and don't have an efferent component. The cervical fibers have an afferent and an efferent component. So this is a pretty long preamble to why would we think about vagus nerve stimulation and addiction. I've talked to you about the neural structures that are involved. Some of the features of addiction that you see is you see a sympathetic overdrive, you see severe anxiety and depression, you see modulation of neurotransmitters, and you've seen that there's a lot of comorbid states with this, all of whom have shown to be responsive to vagus nerve stimulation. So the vagus nerve stimulation modulates neurotransmitters, modulates stress regulation, the parasympathetic sympathetic balance. It modulates endogenous opioid receptors, and as I'll show you. And an area that I don't think I've spent enough time on in this presentation is it modulates central inflammation. Tony did a wonderful job talking about macrophages and glial cells, but there are macrophages and glial cells that, when are activated, release pro-inflammatory cytokines in the brain. And these pro-inflammatory cytokines are deeply associated with the addictive disorders. Vagus nerve stimulation has been shown, oh my gosh, has been shown to be responsive to, the vagus nerve has shown to modulate central inflammation and also promote plasticity. There's actually a device out there approved for neuroplasticity in patients who have had a stroke and repairing motor function. So all of these things kind of make sense. They're just, this is a reference on inflammatory biomarkers. And here are some of the characteristics we see in opioid withdrawal: anxiety, inflammation, nausea and vomiting. And just very briefly, anxiety, we've shown, this is a paper that published last week, that we can, using cervical non-invasive vagus nerve stimulation with a very specific signal, you can modulate sleep and depressed mood, both associated with addiction disorders. And patients to come into this brief little protocol had to feel, were not addicted patients, but had to have difficulty with sleep and feel stressed. And most of the patients by a month out had significant improvement. Chankayata did work on cortical spreading depressions, and this is a rodent model, but showed that IL-1 beta, TNF alpha are both very well-established pro-inflammatory cytokines. They can be modulated with vagus nerve stimulation. Jay Pashrika's group, when they were at Hopkins, looked at abdominal discomfort. That's what we think about when we think about our patients who are going through withdrawal. We looked at improvement in nausea, fullness, vomiting, reflux, indigestion. All of this significantly improved with vagus nerve stimulation. Just kind of go quickly. We know that the vagus nerve stimulation modulates the pituitary hypothalamic axis. We can modulate stress response. We modulate prefrontal cortical function. There's anti-nociceptive pathways because of the activation of the nucleus tractus solitarius. And it may be effective as an adjunct to opioid and withdrawal symptoms. This has been studied now for many years. More recently, we've found that we can modulate endogenous opioid release with specific frequencies. Low frequencies will modulate, you can cause a release of enkephalins, excuse me, and high frequencies can cause a modulation of dynorphin release. So both frequencies are being studied now to take a look at this. And left side is the responders with the big black bars are responders to a lower frequency stimulation. And on the right side, the black bars show a release of dynorphins. So VNS does modulate inflammation. It modulates other brain areas, emotions, amygdala, hippocampus, sleep disorders, and promotes neuroplasticity. And been around for a long time. We've been thinking about use of electrical therapies of some type since the 70s. Most recently, I'm going to fast forward to 2018. The FDA actually granted an approval for a percutaneous, so you have to implant an electrode for the auricular branches of the vagus nerve in the ear. And this was a 5-day study showing an improvement with vagus nerve stimulation in the withdrawal symptoms. 2020 showed that we could improve withdrawal symptoms in what's called NOWS, which is neonatal withdrawal symptom. So if the mother has been on opioids for a long period of time, the child, when born, will go through withdrawal. And it's a very horrific thing if you've ever heard a child with withdrawal. Okay, I'm getting the big hook here. So 2024, we're starting to look at other areas as well, like alcohol withdrawal as well. So I'm going to just go very quickly through the last couple of slides here. I may run 30 seconds over, but cervical non-invasive vagus nerve stimulation showed improvement in withdrawal symptoms. Active is the blue bars here, and sham is the red bars here. It showed improvement in pain scores in patients with addiction disorders. And this is now resulting, this kind of work that's been done resulted in NIDA giving Doug Bremner a $6 million grant to study cervical non-invasive vagus nerve stimulation for addiction. Another, this was in adults with withdrawal symptoms, and this was actually a blinded randomized controlled trial, but the blinded portion was only 30 minutes. And there was basically no response in the sham arm for the first 30 minutes. I'm not showing that picture here, but this is from the paper here, but over 5 days with auricular nerve stimulation, they had significant improvement. Similar to what we found in other areas, depression and PTSD symptoms of patients with addiction disorders were significantly improved in at onset to long-term. Opioid withdrawal, they didn't do it as a double-blinded study, but rather they did it as compared to natural control, but a significant improvement for the children with the neonates with opioid addiction. So I'm gonna end with a couple of challenges and thoughts here. We don't fully understand all of the mechanisms. It's more than just release of endorphins to modulate pain. It does a lot of different things on modulating dopamine, probably the neural structures. The studies that have been done to date have been small and the kind of variable designs, lack of controls in some of the studies, and we're still working through various stimulation parameters. You see what happens with high versus low and dynorphin versus enkephalins, et cetera. Treatment with neurostimulation has been challenging because it's not widely accepted in the paradigm and people don't want to pay for it. There are a number of studies ongoing on opioid and other addictions. There's a couple of things that are happening. And I'm going to conclude that with a thought I hope to have given you today, just kind of a different way of looking at the problem. Maybe not the conventional way, but sometimes looking at it from a different angle can give you a new view on things. I do think that addiction is a biobehavioral problem, and I don't believe that vagus nerve stimulation in and of itself is going to be the sole solution to problems of addiction, but it will be an adjunct to helping people withdraw, maybe minimizing neuroplasticity, et cetera. It makes sense on the pathways that are established here and what's going on in addiction, and we need to do more work. Thank you very much.
We have a minute for a few questions. Julie.
Yeah, that was great. Thank you. And I was really intrigued by the comment about the auricular fibers and their ultimate target in the brainstem, which I didn't know, embarrassingly for me. And then I'm curious because we're seeing a lot of development in terms of like percutaneous stimulation in ear devices in Europe, the ones that you mentioned. Are you noticing any systematic differences in efficacy for these different indications for the fibers in ear versus the ones in the neck?
So yes, but it's a very complicated answer. So we should probably spend an hour later, but I'll give you the 30-second view. Some of the stuff I didn't show you is the Air Force is doing work on vagus nerve stimulation and enhanced learning. And they're now using it to learn a new language 30% faster. They're using it to retain that new information for 90 days, for example. They've looked at, in their study, they looked at auricular and cervical, and auricular didn't work, cervical worked in this one model. So I think that if you're just looking at auricular vagus and cervical vagus, in my view, is a better approach because you're getting so many more fibers, so much more activation. You have afferent, efferent, et cetera. Having said that, I think there's something to be said to some of the new auricular therapies, one of which stimulates the tragus, stimulates the auricular templar, the trigeminal, and the C2 and C3. They're slamming the NTS with multiple, and then they implant it and they leave it on for 20 days. They're showing some pretty remarkable findings in terms of diabetic neuropathy pain being cured, diabetes being cured. And that study that I'm referring to It's being replicated at Cleveland Clinic now, but it's a different strategy. It's a different thought process than just saying vagus, vagus. There's a lot out there on auricular vagus. I think it works. And every time I say, so most of my work has been on the cervical vagus, but some of it's been on auricular. Every time I see the auricular vagus work, I go, wow, that's pretty cool. I bet this could do a little bit better. But, so it's a very long-winded answer to, yeah, there's differences, but I can't really tease it all apart yet because we're doing different things.
There's a question from Zoom. I think Alan Bastow raised his hand.
Oh my gosh, I can't take a question from Alan. He's too smart.
I've had my coffee, so don't worry. No, so thank you. I have actually several questions. One is, when you stimulate the vagus where you stimulate it, you basically don't talk about the efferents. It's almost as if it's all afferent, but obviously there's an enormous cardiovascular consequences of stimulation. So my first question is to what extent that might be relevant. The other ones you kept saying the cell bodies. I assume you're referring to the postsynaptic cell bodies in solitarius, because of course the primary cell body is nodose, and the question is whether maybe in animal studies that there's anything known about just selectively stimulating the afferents, getting away from the efferents. And the third question is, everyone seems to have forgotten about the work of Alan Randich and Jerry Gebhard, who actually showed many years ago that there's a link from the vagus through solitarius going descending through raphe magnus as a pain control measure. So is that basically just ignored now, forgotten that that's not a relevant condition?
This is all Mark's fault because he only gave me 25 minutes here. So let me take each question in order. So the first comment is there has been a fair amount of work on afferent to efferent vagus, and you mentioned bradycardia. The device that I'm most familiar with out there, I built, and it was specifically designed to not activate the C fibers that go to the cardiac. So in about 100,000 patients that have been treated, we've not seen any kind of bradycardia or bronchoconstriction, which can happen with excess vagal stimulation.
Very cool.
So it is a 5,000 hertz sine wave that's bursted at a certain frequency, and you'd have to go about 10-fold more in amplitude to activate the C fibers than we actually can do. So it's a very, very safe approach. For the purposes of this talk, I did only really cover afferent stimulation and not efferent stimulation, but had you came to my talk at Hopkins last week, I was talking all about the efferent stimulation in rheumatoid arthritis and diabetes and gastrointestinal discomfort. And I think, frankly, Jay Pashrika's work was all on efferent stimulation. And then finally, I would say I have not forgotten about the work of the central leaking in the brain, because of course, what happens with auricular stimulation, I am sure, because there is a peripheral neuroinflammatory response that you can modulate with peripheral stimulation, even with the auricular branch, but there has to be a link in the brain, and it's probably through the raphe magnus, as you mentioned. Similarly, with cervical vagus nerve stimulation, in terms of the bronchodilation that I started to talk about, interestingly, if you cut the vagus distally to the area of stimulation, you lose your effect in bronchodilation. And when we got started with this, we thought this was an end-neck nerve problem, but it turns out that there is a central afferent, then leading to an efferent sympathetic response that's occurring, that's causing the bronchodilation. So it's a very complicated clinically on what's happening. And I defer to you smart brain scientists to tell me exactly what we're doing, but it's afferent, efferent. You can't really separate the two because it's all linked there. And yes, I was referring to the NTS as where the dorsal and ventral vaguses are.
Thank you very much.
Alan, you're my hero. Next, you're second to Tony.
Any others? Eric.
Peter, unlike Tony, you actually have treated patients in the clinic, so I have high regard for your skill and knowledge in there.
Not so well, but I have treated them.
No, that's what I've heard. But anyway, so the question is just simple. Like, if you could design a little patient protocol whereby patients would get transcranial, transcutaneous vagal nerve stimulation in a pain clinic, roughly how would that be designed? Forget about the reimbursement for the moment, but just how would you apply it? Patients come in for their routine monthly visit and so on. How would you design briefly a plan where they could get transcutaneous VNS as part of ongoing chronic management of their pain disorders?
Well, first of all, I would say that VNS is incredibly safe. That's one of the good news. And there are some downstream effects. In response to Alan's earlier question, is can we distinguish? I'm just reading a little into it, but there is great work going on right now trying to distinguish out which fibers we can stimulate and how do we get to various fibers by where they are in the vagus. My own view is it doesn't really matter because the downstream effects are all positive. Or the unknown effects. So you can have improvement in your anxiety if you're treating your headaches. You can have improvement in your gastrointestinal problem, so you have improvement across so many different domains. When I say that, I sound like a snake oil salesman, and that's really not what I want to do. I just want to say that the vagus is involved in everything. And if I were to start over today, in terms of some of the clinical research that we've done, I would probably start with measuring some metric of vagal tone, heart rate variability. There's questionnaires that can really get to some of these things as well. And try to tease out who are the patients, and I suspect there's going to be a lot of them, who are not in an adequate sympathetic parasympathetic balance. I would start with trying to figure that out. And it crosses many different disorders.
So would there be any harm in every patient having a short treatment of transcutaneous VNS at every monthly office visit? Would it be of any benefit? Would it be of any harm?
So look, you never say no harm, but it would be very low risk. But the benefit that you get out of vagus nerve stimulation is in today's world is someone can just take a little device home and they will get a benefit if they're using it 2 to 3 times a day. They use it for their anxiety, their sleep disorders, et cetera. The Air Force is using it for training pilots and language acquisition, but you got to use it every day. You got to use it before you think. So the reality is I think we're going to get to a point where there could be a lot of people who would benefit from this. And I think it will solve some of the healthcare problem.
I'm going to give you one more chance to give me a yes or no.
Yes.
Every visit, monthly visit, what's the harm?
There's no harm. And you will determine in some of the patient's maladies, let's say they have headaches, you can determine right then and there, is that a patient that could benefit? Because they'll get better right away and they can go home with their own device.
Thanks. Thank you.
Yeah, thanks.
All right, thanks so much.